Hello, my name is Maria Wyant, and this is my video for Assessment 1, Collaboration and Leadership Reflection in NURS-FPX4010. In this video, I will discuss an experience I've had in my nursing career that required interdisciplinary collaboration. I will address aspects of the collaboration that help the team make progress towards relevant goals and outcomes, aspects that could have been improved, and identify ways poor collaboration can result in inefficient management of human and financial resources. I will also identify evidence-based practice, interdisciplinary collaboration strategies to help a team achieve its goals and work together. Interdisciplinary communication is the foundation by which I do my work. As a PACU RN, it is essential for me to communicate with the anesthesia and OR staff to adequately care for my patients. In quote, an examination of nurses' empowerment and speaking up during post-anesthesia clinical handovers, end quote, it is stated, quote, inadequate team communication may contribute to as many as 52% of patient safety incidents. Ineffective clinical handover communication during perioperative care can result in suboptimal outcomes, contribute to preventable patient harm, and negatively affect the quality of subsequent patient care. End quote. Redley et al., 2021. The type of surgery, dressing, devices, medications given, past medical history, and baseline assessment are what I base my interventions and care on, and what determines whether I need to call the surgeon or anesthesiologist to question an order. In nursing school, we learn about SBARs, and as students, we gain practice using them to guide how we give report to our colleagues. According to the journal article, quote, Surgery Nurses Awareness on SBAR, end quote, quote, SBAR training delivered to nurses has enhanced the perception of effective communication and cooperation by healthcare professionals, end quote. That's by Vitan, 2021. Currently, I work 2 separate PACU positions, one in an outpatient surgery center that primarily performs orthopedic cases, and another in a main OR PACU at a busy level 2 trauma center. While similar in nature, both roles vary vastly to each other. One of the main ways they vary is through their communication. At my outpatient position, I regularly receive report on patients while the stretcher is still moving and before I've had the opportunity to attach a patient to the monitor. It can be a challenge to focus on what the OR nurse is telling me while I'm also making sure a patient's chest is rising symmetrically and their oxygen saturation is above 92%. One experience in particular, I received report from the ORRN telling me the procedure done, mLs of local given, dressing, allergies, before I got a chance to lock the stretcher, and my anesthesiologist left without saying a word before the completion of the first set of vitals. After the anesthesiologist left, the monitor alarmed that the patient's oxygen saturation was 85% on 3 liters via nasal cannula, and the patient began to audibly obstruct. The patient's blood pressure was also 79/43, and the cardiac rhythm showed sinus bradycardia with a heart rate in the low 40s compared to the preoperative reading of 153/80 and normal sinus rhythm. I opened the patient's fluids up and performed a chin lift to open the patient's airway while one of my colleagues paged the anesthesiologist overhead. On arrival, the anesthesiologist gave 0.4 milligrams glycopyrrolate IV push and placed an oral airway to keep the patient's airway patent until he was more arousable. The anesthesiologist did not take long to arrive. However, had he waited at the bedside until the first set of vitals were complete, we would have been able to intervene sooner and more efficiently for this patient. In this instance, I did notify my manager at the end of the day my concerns regarding handoff reports and suggested if it could be possible to at least wait until the patient is fully attached to the monitor before starting handoff report, and anesthesia remain at the bedside until the first set of vitals were done, which has led to some improvement. In contrast, when I work at the hospital, the ORRN and anesthesiologist will wait until the receiving nurse is ready to take report. The tech or another nurse will assist in hooking the patient back up to a monitor, or if you do not have the extra hands to help, the team will wait until they can have your full attention. As you can see, this is my report sheet. This is the report sheet I use at the hospital, and it is very detailed and organized. It provides me areas where I can circle what will apply for the patient and blank spaces to write down any pertinent medical history and information. Being given the time to listen, write things down, and keep my information organized helps me to feel confident in how I give report to the next nurse and ensures the patient has no lapse in care due to poor communication. Communication doesn't end after a patient is discharged either. In the perioperative setting, after a patient has been discharged, it is also important to follow up with them to see how they are doing. At my outpatient position, the biggest complaint we receive is our complicated phone system. Patients regularly have reported how difficult it can be to speak with someone about a post-operative question or complication they may have, or the wait times being exceedingly long. There are instances where I have made follow-up calls and patients report they have gone 24 hours without any pain medicine due to an issue with how the prescription was sent and being unable to get a hold of anyone. This is a major delay in care that ultimately causes harm to the patient. One solution that is currently in the works to prevent future occurrences of these situations is using digital communication. Article, quote, Patient Perspectives on Communication Pathways After Orthopedic Surgery and Discharge, an Evaluation of Team-Based Digital Communication, Qualitative Exploratory Study, written by Jensen et al., goes into detail on the positive impact of multidisciplinary digital communication after orthopedic surgery. This study was primarily done in Denmark, but the results showed that quote, patients experience difficult communication pathways after hospital discharge and a lack of information due to inadequate coordination of care. E-dialogue was used by 84%, so 26 out of the 31 patients, and they suggested that it provided a sense of security, coherence, and proximity in the aftercare, rearranging communication pathways for the better. End quote, Jensen et al., 2024. Through effective interdisciplinary communication, teams progress towards providing excellent patient-centered care, and patient outcomes are improved. This concludes my video on interdisciplinary communication. Thank you.